Good evening. So I am Gavin Quigley. I'm one of the neurosurgeons in Belfast. I have the distinction of also having been a consultant neurosurgeon in Beaumont Hospital for 3 years. So it's fair to say I have straddled the border. I did my neurosurgical training in the Walton Centre in Liverpool, which some of you will know. Dr. Leach certainly remembers it well. And I'm going to cover a couple of the things that Norman touched on. I'm going to go back to basics a little bit, because surgery, if it becomes too complicated, then surgeons find it hard to follow. And if the surgeon finds it hard to follow, they find it very difficult to explain to patients what's going to happen. So I have a fairly simplistic view of epilepsy surgery. So you can remove parts of the brain that are misbehaving, causing seizures. If you can't find a piece of the brain to remove, then you might be able to put something that will stimulate the brain to try and block the abnormal signals from bouncing around. Or in very occasional cases, you can try and restrict the abnormal electrical activity and try and minimize its spread. So this is the Engel classification of outcome after epilepsy surgery. And this is the simplified surgical version, okay? Because the neurologists have more complicated. They keep reinventing it, and we can't really keep up. But if you look at it, what we're really interested in is kind of class 3 and upwards. We're not really interested in anything else. And so what I would caution all of you is, when you read surgical articles or you read a drug trial, make sure you look at the raw data. Make sure that nobody is casually drifting over the fact that actually a lot of patients did quite badly. It's really important that you understand what's being measured. So if I talk about the most straightforward way of epilepsy surgery, this has been around for as long as any neurosurgeon has anyway. You're generally trying to remove the focus of your epilepsy. You might be removing something abnormal, a low-grade tumor, something you were born with, some sort of blood vessel abnormality, some form of funny cortical abnormality of the brain. Or you might be wanting to remove portions of the brain. So the temporal lobe is the most common propagator of seizures in terms of anatomy. That's where most seizures seem to come from. It's not universally the case, but a lot of the time, that's what we're interested in. And at the most radical extreme, you can remove a whole hemisphere, particularly if that hemisphere is congenitally abnormal. So you could take it out, and it can be very successful surgery, but there's a very small number of patients who are suitable for that type of radical surgery. So if we talk briefly about lesionectomy. Now, neurosurgeons use the word lesion in a lot of euphemistic senses. We like to say, oh, it's a lesion. Now, that can mean anything from something that you were born with that's totally benign to something that's much more unpleasant. Okay, so we talk about lesionectomy. We talk about removing something that's abnormal that you can see on an MRI scan. So the first thing you have to decide, and this is where the neurologists come in, is that lesion actually responsible for your epilepsy? Because about 5% of the population have some sort of abnormality on MRI, maybe as much as 10%. And those patients are frequently found to have some sort of abnormality because they've scanned, because they've developed ringing in their ear, they've got tinnitus, they're a bit dizzy, they've had a few vague symptoms, they get an MRI scan. And so they come with an abnormal scan, and then they may have a diagnosis of epilepsy. So the question is, do the two actually correlate? So you need to find out whether your electrical activity really comes from the area of the abnormality. You need to find that the seizure type is what you would expect from a lesion in that part of the brain. And lesions in the back of the brain are generally not likely to cause epilepsy. You might still want to remove our lesion, in inverted commas, because you want to know what it is, or you think it might bleed or cause problems. So it may be justifiable to remove it, but for non-epileptic reasons. And this is very straightforward. This is a blood vessel abnormality, something called a cavernoma. It's like a birthmark on the skin. It's a little small capillary malformation. They're very common. We see lots of them, and they're a very common cause of seizures. But they also tend to bleed. So we may be justified in removing them simply because of the risk of hemorrhage. But that's in a pretty good location for epilepsy. It's in the temporal lobe. It's right on the surface. It's surgically accessible. It's right-sided. So if you could be convinced that the seizures were coming from this area, this would certainly be someone you'd be interested in operating on. And so she's had her cavernoma removed. You can see it's gone. And at 5 years, she's had no seizures. She's now off medication. And that's great. But the reality is that is not everybody who has epilepsy surgery. Now you can see this. This is actually the same type of lesion, only much bigger. Slightly more difficult location. It's a cavernoma. It's big. It's been there for a long time. Once you've got a lesion that's responsible for epilepsy, and you've had it for a long time, the longer you leave it, the worse your surgical results are. Now, we don't really understand why. That may be because of a kindling phenomenon, that there's abnormalities develop around the lesion. But there's a definite push towards trying to do epilepsy surgery early. So ideally in children. And in the UK, there are now 4 designated epilepsy centres that are solely responsible for all the children's epilepsy surgery. And you can see it's beautifully removed. I'm very pleased with myself. I've taken it out. Technically, what a lovely operation. But still got seizures, not cured. Okay? So just because you can do something surgically doesn't mean that it's always going to have the desired result of being free of seizures. Temporal lobectomy is the big one. It's the most common sort of epilepsy surgery procedure worldwide still. 70% chance of a good result. You'll notice I've put good result. I have not put cure or freedom of seizure or anything like provocative like that. But 15 to maybe 20% have very little benefit. Now, some of those are because we've got it wrong. Either we haven't removed enough tissue or we've got the diagnosis wrong and the seizures are coming from somewhere else. You still need to carry on with your medication. You need to know about the patient's psychology. There's a lot of interplay in the temporal lobe, and a lot of structures that are involved in emotional behavior. And if you don't get it right, and you don't warn the patients, then you end up with disasters. And I wouldn't say the burden of normality is being seizure-free. It's everything else that's gone along with it. And what happens is if you make the patient seizure-free, they still have trouble with their memory. They still have difficulties that they've had all their lives. And so as surgeons, we're not particularly good at that. That's not our gift, generally. So you have to be really careful that the patients understand what they're getting themselves into. So there's a long assessment process. This is the sort of way that you go about it. You want to make sure that they've got a good history. Basics, as Norman said. You want to prove that the electrical activity is where you think it is. You want to try and make sure. You might need to go to invasive monitoring to prove that your electrical activity is really coming from the part of the brain you think is abnormal. You want to do MRI scans. You want to do psychological testing. You might want to, more than likely you'll want to do a WADA test at some point, and that's where you can determine which side of the brain has dominance for language. And you want to make sure the patient's fit enough for an anaesthetic and a pretty prolonged surgical procedure. Just a little bit of invasive monitoring. Apologies, I don't have a photo of a robot, but this is where the robots come in. So invasive monitoring is where you put electrodes into the brain. And you can put as many leads in as you can conceive of. Now, we try and limit it because obviously every pass of an electrode through the brain has a small risk of hemorrhage. So if you do it once, you might have a 1 in 20,000 risk. And every time you do it, that risk rises slightly. So we have to limit our enthusiasm. And this is where robots are coming in. If I show you a little bit, I'll show you a picture of how we used to do it. But in essence, you may be in for a pretty prolonged hospital stay. You may have to come off your medication so that you perform. The seizures happen. And of course, one of the problems is if you give a patient a general anaesthetic, you put a lot of electrodes in, they've then had a major general anaesthetic for several hours, they're very unlikely to have seizures for the next day or two because they've been anaesthetized. So the patients are then stuck with being in hospital, being off their medication potentially, and the risks that are associated with that. WADA testing a little bit. WADA was a Japanese doctor who came to Canada. And this was a way of putting one side of the brain to sleep, in essence, very simplistically. And so what you need to do first is you need to do an angiogram. So you take a picture of the blood vessels. You have to prove that there's not significant cross flow from right to left or left to right. Because if you did, and you gave the injection of barbiturate, then the whole brain would go to sleep. Now it comes back, okay? So don't feel that it's very short acting. The patients have to be rehearsed, and the psychologist or the language, but whoever's doing the testing has to know what they're doing. And you want to prove which side is capable of maintaining short-term memory and also which side is dominant for language, because that's very important. Because you can all imagine what happens if I take out the side that does short-term memory or language function. You're not better off, even if you are seizure-free. There's been a little bit of work, particularly in the UK, about functional MRI scanning. There is a suggestion that it might replace WADA. I don't really think we're quite there yet. It's very dependent on which epilepsy centre you talk to, and it's very radiology intensive. And what you really look at is that there's a series of questions for the patient. They're asked to perform a certain routine. In the MRI scanner, there's a little flip down screen that asks them to think about rhyming, words that rhyme, think about semantic things, so fixed decisions that they might be making. And what you're looking at is the areas of the brain that are most active during those processes. And so you get an idea of which hemisphere certainly is the most active one. We've restricted our use of fMRI to prove which side is dominant for language. We don't make any other judgments beyond that. And you cannot completely tell which areas are dominant for language because they're completely interlinked. So you can't say, oh, that's one area, because it may be dependent on the other areas. So it's a bit too simplistic. This is the sort of patient we're looking for. Apologies, I don't have a laser pointer, but you can see on the left side here, if I go over here, this area here is smaller than that one. It's a bit bright. So this is a bit of hippocampal sclerosis. This is the sort of patient who's likely to go for epilepsy surgery. I'm not going to show you any pictures of the procedure, don't worry. Okay, so the patients are generally asleep. They're placed on their backs. They're put in a headrest. And what we do is we make a scar that looks like a question mark. So this is a classic temporal lobectomy. We then remove the bone that goes along with that. And then we make a cut along here, about 5 centimeters from the sort of end of the bone. We make another cut there. And then we cut along across the line of the Sylvian fissure. There's a big blood vessel under this. You see this black line here? There's a really big blood vessel under there. It's very unpleasant if you get anywhere near it surgically. So we try our best to stay away from it. And then you remove the medial structures, which are the hippocampus and the amygdala. And that's a classic temporal lobectomy. The risks, obviously, the usual types of surgical risks you can think of, infections, post-operative hemorrhage, jaw is sore, you've got to cut through the muscles there. You can have seizures. If you're really unlucky, you can damage a blood vessel that might leave you with a weakness. You can get a visual field defect. And that's a big deal because if you're going to have epilepsy surgery and it works and you get your driving license back, if you're left with a visual field defect that means you can't drive, it's a waste of time because that's what the patients want. You can do fancier operations. I think mainly because the surgeons like the sound of amygdalohippocampectomy, but really it's a way of limiting the amount of resection. And what you do is make a small corridor in, and then you remove this hippocampus and a bit of the amygdala. And the hippocampus is the thing that looks like a seahorse. That's why it's called hippocampus. So on the side, it's supposed to look like a seahorse. It kind of does. So in theory, you've got a reduction in the side effects of removing too much brain. But it's a difficult operation to do sometimes. You have a very narrow corridor of access. You don't have a lot of room to work in. And if you get it wrong, you still have trouble. And this is what you end up with. You can see the hippocampus is here, and then this one's gone. This is just a blood vessel and a little bit of choroid, which is the stuff that makes the fluid in the brain. So that's resective surgery in a nutshell. If I go for stimulation. So stimulation's advantage, if you like, is that you can turn it off, take it out. You haven't destroyed anything. It is in theory reversible. And if you could combine it with a way of recording either seizure activity or EEG, and you could make that join up, then that would be very promising. It's generally pretty complex and quite time-consuming, although that's not fair to say about vagal nerve stimulation. There's the cost. You've got batteries to replace. You've got to look after it. You've got to get it checked. So it's not something you can fire and forget. You have to keep going. There's lots of different places you can try stimulation. The cosmetic appearances are sometimes not great. Batteries stick out. They're not very glamorous, especially if you have a battery under your collarbone. It's, an infection is a problem. Because if you get it infected, you usually have to take it out and start again. So briefly, deep brain stimulation. This has been around for quite a long time. Predominantly, this is done for patients with movement disorders, Parkinson's, tremor, dystonias. Those are the big indications. But there has been work over the years for trying to stimulate areas of the brain that might reduce seizure frequency. There was a trial a few years ago called SANTE, which is surgical anterior thalamic nucleus stimulation or something. And nobody really knows what target is the best one for deep brain stimulation. But what you really do is you put this mild sort of electrical current to a target somewhere deep within the brain. It's usually high frequency stimulation. That seems to inhibit the neuronal firing. But the truth is we don't really know. Now, this is a little bit of how you get them in there. And this is the other way we would put depth electrodes in. You can see that the problem for us is the skull is round, and that doesn't lend itself to X, Y, and Z coordinates. So what you have to do is make the skull into a square box, and then you've got an X, Y, and a Z, and you can target things. So trigonometry, contrary to popular belief, is actually useful for neurosurgeons. And this is where robots are coming in. Because what we used to do was we'd manually dial in our coordinates and we put our lead in, and that's fine if you're putting 2 electrodes in, one on either side for DBS. But if you're going to put 7 or 8 depth electrodes to measure EEG, then that can take 3, 4, 5, 6 hours because you have to manually dial in each coordinate every time and move around. But if you use a robot, the whole thing can be automated. So the robot isn't a robot in the sense it doesn't walk up and talk to you. It's basically a motorized tool holder. So what it does is it holds whatever it is you want to do, a drill, an electrode, and it moves from place to place. But because you program them in sequence, it's much faster than doing it manually. So that's why you can get a lot more electrodes in, and that's where robotics has come into epilepsy surgery. Your DBS system is very much like any other stimulator system, spinal cord stimulation, deep brain, vagal nerve. It has a battery and some leads. The Medtronic one looks like that. You have a couple of leads that go into the brain and then a battery, and that's a rechargeable one, so you can charge it. Boston have come on the market in the last few years. They've got more contacts and maybe a bit more scope to stimulate across a wider target area. SANTE study was published a few years ago. It was a multi-center, double-blinded, randomized, the whole FDA approved. At the bottom, though, my little caveat, it was industry-sponsored. What I would say to all of you is that industry-sponsored trials tend to have better results than those are not sponsored by industry. That's universally true. I'm not suggesting anything untoward. I'm just relaying the fact. These guys did pretty well. Now, the ones that did best are the ones who had temporal lobe epilepsy, who generally always do better in surgical trials. You can see that what they did was they implanted them and then they randomized them to on or off stimulation. And pretty good results at 2 years, similar to probably a new drug, but it seems to be maintained. Again, complications, infection. You're putting something under the skin, you always have a problem with infection. So no one knows what the right target is. There are other groups using different targets around the world. There's a group in Mexico who talk about something called the medial lemniscus. They've done it for years. They have good results. Other groups have used, there's a whole variety of target areas potentially, and we don't know which one is the right one. So I'm going to talk very finally about a way of reducing the epileptic spread. Because basically what you've got is uncontrolled electrical activity spreading across the brain. And that's a bad thing. Callosotomy is a way of dividing your 2 hemispheres. So it can't spread from hemisphere to hemisphere. Now, I can see you all thinking the neurosurgeons have gone mad this time. That's partly true. It is a pretty radical procedure. It's not done very often, but it can be very useful for a very small group of patients. So patients who aren't suitable for classic resective epilepsy surgery, patients who have very profound drop attacks or are very disabled, then a callosotomy is an option. And what you divide is the corpus callosum, and that's the area that joins the two hemispheres together. And you end up with a scan like this. It's pretty dramatic. But there's a catch, as there always is with surgery. Patients speak less. Some of them are truly disconnected, so that's a very unusual situation. Mostly this is done in children as a palliative procedure. And you can get worsening of other types of epilepsy. This is an old operation that sort of comes and goes again with fashion. It was very fashionable for a while, and then it became unfashionable. And now it may have a role in a very specific epilepsy syndrome that I don't fully understand, nor can I pronounce it. This was a way of trying to reduce epileptic spread in areas of the brain that were really important. Okay, so if you've got, most of you are right-handed, just at a guess. And even the ones who are left-handed, most of you are still left dominant for language, short-term memory. Not completely, but a fair number of you. Some of you have bilateral representation. So you can imagine that on the left side, you probably don't want to be chopping out too much because you can't put it back, okay? You can't repair epilepsy surgery. Once you've removed it, it's gone. So someone thought about this, and Whistler and Morell talked about this, and what they came up with was an idea that they could make little cuts in the surface of the brain, the cortex, to stop the epileptic activity from spreading, and that you wouldn't cut deep so that you didn't damage the fiber tracts that relay information, if you like. And it's quite a complicated procedure, and it takes forever to actually do because you have to cortically map. So you have to prove that your area is the electrical abnormality. You then have to go all the way around it very carefully and make these little tiny, you can see every 5 millimeters you make a cut. And there's a this special knife. Every 5 millimeters you make these little cuts. And you have to do that all the way around the abnormal focus. And that's what it looks like under a microscope. It's pretty featureless. You know, brain, it looks like brain. And it's not easy to see the focus. You're relying on the electrical tracings. So Norman showed you a picture of this. This is something called neuropace. This is an attempt at stimulation plus recording, but it is invasive. And what you get is you get this box, and the box gets set into the skull, and it is a EEG recorder, and it transmits data to the company server, and they have thousands of years of EEG data now. So one thing I would say about it, even if it doesn't work as well as we hoped, it has got massive amounts of EEG data. And what you have is a depth electrode type thing. You can see the small one, and then a cortical one that sits on the surface. And so what you can end up with is you can end up with this cortical lead and then your depth lead. And what it does is it records the EEG. And if it sees the start of spike wave activity or something that looks like epilepsy, it will deliver a stimulus. And it can deliver the stimulus to whichever one you like. And in theory, that should stop the seizure because it's a bit like a defibrillator. You hit it with a current, you stop it, it resets itself. Now, the problem is, as you can all see, it only works if it's in the right area. And that's the difficult bit. So it only works in people who have really predictable seizures that are coming from there. But I think it's a work in progress. It doesn't, as far as I'm aware, have European approval yet, but it is FDA approved. Now, this brings me to this. This is the neuropace results, okay? And if you look at that, you think that's the mean seizure reduction, but that's not mean, that's a median, okay? And this is what I harp on about when you read trials. There is a difference between mean and median. Mean is an average, and it can be skewed by outliers for whatever reason. Median is more predictive of the middle, but it can be used if you want to get rid of some outliers and give you a slightly better looking result. So you have to be careful what the statisticians have written. And that's what I would say to all of you. Don't believe necessarily what I tell you. I will tell you to the best of my ability, but I don't always get it right. Neurosurgeons and surgeons in general are not statisticians, and we can be fooled by clever statistics. And so we can believe the hype. And the other thing you can see is the number varies throughout the years. But I think the trend is overall, and what they're saying is that the longer you have your neuropace, the results get a bit better. Which brings me to the last 6 minutes, vagal nerve stimulation. Been around for quite a while. I'm sure some of you have this. You've seen it. It's very common. You deliver a stimulus to the left vagus nerve in the neck. Not totally sure how it works, but it definitely reduces seizure activity. It's not an alternative to epilepsy surgery, if you like. It's not something that we would normally say, oh, you can have a temporal lobectomy or a vagal nerve stimulator. That's not what it's about. It's an adjunct. And it's usually considered with patients who've either not suitable for epilepsy surgery or maybe haven't done so well with epilepsy surgery. There's a few patients that we probably wouldn't implant, although this is historic. And I think the diabetics is not really relevant anymore. Insulin-dependent diabetes mellitus. Apologies. Sorry. I thought I'd taken all my... COPD is chronic bronchitis, if you like, chronic airway disease. Again, that's not a particular problem. Cardiac arrhythmias as well. We've done a number of patients with very dubious heart rhythms, and we haven't seen any problems. So usually they're done asleep, mostly because when the patients talk, it's very hard to get hold of the nerve because it moves up and down a bit. So it's usually easier with them asleep, although you can do it under local. And you expose the vagus nerve on the left side. And the reason we use the left nerve is because it has less cardiac events. The right one tends to go to the heart. And so in theory, if you stimulated that, you might get some unwarranted cardiac events like heart rhythm changes. So the left was the one that was the obvious choice. And you can see it. I mean, it's not a hard nerve to spot. It's pretty big. Carotid arteries on that side, jugular veins on this side. So as long as you don't make a big hole in either of those, it's fine. Actually, the artery's fine. It's the vein you want to be careful of. And that's what you do. And then the trick is that, and Cyberonics always show this lovely picture, and they show you this picture of the nerve and the electrodes, okay? And they have a little demonstration device, and I can see Darren shaking his head. He helped me somewhere in the back. And they say, oh, you just, you wrap it round. And that's easy if you can get all the way around the vagus nerve, but when it's stuck in your neck, that's almost impossible. So this is the most swear word inducing neurosurgical operation, because you'll put them on and think, oh, it's 5 minutes. Wow, that's great. And then they all pop off as you go to anchor the leads, or you spend 3 hours and they eventually go on. So, but the design is there for a reason, that once it's on, it's very stable and it tends not to pull on the nerve. So it is a clever design, and we're just stuck with the logistics of it. So VNS, about 20 to 30% will have some sort of vocal alteration because it stimulates the vagus nerve, and the recurrent laryngeal nerve supplies your vocal cords, so you will get some hoarseness. You can always turn it off if you need to make a phone call, so it isn't a problem. Cough, again, related to that. Funny pins and needles is a bit difficult to define, but patients do report it. And obviously you can damage important things in the neck if you're not careful. Generally we don't, but this is the more modern version of what it looks like. So you've got your generator, and that goes up over the chest and delivers its stimulus to the thing. And in usual settings, when we turn it on at first, it's on for about 30 seconds and then it's off for 5 minutes, and it cycles continuously. So whether you're awake or asleep, it's doing its thing, and you can change that. There's multiple different, variations on stimulation parameters. And what that seems to do is it seems to reduce the likelihood of seizures, as well as shortening seizures if it happens to occur at the time of a seizure. But it is not, and I will stress this, a cure for epilepsy. It's a pretty straightforward procedure, usually. It takes an hour. We send most of our patients home the same night. you have a scar on your chest and a scar on your neck. It's not, I'm reliably informed, hugely painful, he said. Like any good surgeon, he's never had it done. And it's not brain surgery, okay? But it shouldn't be underestimated. There is still a risk of infection. There's still a risk of complications. And I suppose where we are now with VNS is that traditionally, the way you gave an extra stimulus was that you waved a magnet over it. And that was great if you knew you were going to have a seizure or someone else knew you were going to have a seizure. But there are a couple of problems with that. So, seizures at night. Can't find the magnet. Patient can't do it. There's not enough time to use the magnet. So, this is where we are now, sort of, gosh, about 30 years in the making. This model of VNS, this 106 model, will actually record a surrogate marker of epilepsy. Okay, so what it does is it records your heart rate, and it records your heart rate continuously. So if you gradually walk up the stairs further and further, your heart rate will rise gradually, and it won't do anything. But if your heart rate suddenly jumps beyond a predetermined limit, it will deliver a stimulus. Because in most patients, their heart rate rises just before the seizure starts, and there's lots of, again, the neurologist can explain this to you, there's lots of clever people who've thought about this, and there seems to be a pathway between this onset of the seizure and the heart rate rising. So this is a surrogate. It's not, it does, just because your heart rate rises, it does not mean that you're having a seizure, but this is a way of using what we know to try and improve the delivery of stimulation with a VNS. And so it can react to that change and deliver a stimulus automatically. Now, you can imagine that in sleep, that might be particularly useful because the patients sometimes will have prolonged seizures in their sleep and they don't know about it. It's probably very bad for them in the long term. But if this thing realizes that you're having it, even if it gives you a couple of extra stimulus unnecessarily, it's probably a good thing. So you might stop the seizure, you might shorten it, and you might decrease the intensity, or you might recover quicker if you can get your stimulation around the time of your seizure. It's pretty safe worldwide, nearly 100,000 people. There doesn't seem to be any major interactions, unlike drugs. You can still have MRI scans. If your system is working, you can still have an MRI scan of your brain. We've scanned a number of patients without any difficulty. And you can combine it with other treatments. This is my old slide, probably from Liverpool, of what we thought about VNS nearly 20 years ago. And this is where we are now in terms of long-term follow-up. So these guys, this is the important one here, 59 months. It's approaching 6 years. Epilepsy is a lifelong disease, and if you start to measure things at a year or 2 years, it's probably not the best measure because the patients are likely to change beyond that. So you want to be looking at long-term follow-up, big number of patients. So you're now getting to 64% have seizure, greater than 50% seizure reduction. And if you look, this is interesting, this is a smaller study, but what seems to happen with VNS is that it carries on getting a bit better, and that was very similar to what you saw with the NeuroPace data, and it's probably because of similar mechanisms of action. So what I would say about VNS is you have to bear with it. It takes a while to get it right, and it is not an immediate cure. And the one last thing I would say, you talked about SUDEP a little bit. If you look at SUDEP in patients with VNS, there's about a 60% reduction in the rates of SUDEP. Now, I am not suggesting that is because of the VNS. All I'm saying is observationally, that's true. It may be that these patients look after themselves better. They're more likely to take their medication. They're more likely to come to doctor's appointments. They might be a better group of patients. We don't know. The trial to do this as a primary outcome is difficult. You need a lot of patients and a long follow-up. But there does seem to, and my suspicion is this is because the stimulator is working at night and they don't get into so much trouble. But I can't prove it.